Hello, everybody, and welcome to the 20th Annual IHA Virtual Health Literacy Conference. My name is Michael Villaire. I'm President and CEO of the Institute for Healthcare Advancement, or IHA. Welcome to the conference. I'm so glad that all of you are here. We are going to go ahead and jump right in now. Rachel, if we could go ahead and get the slides going there, that would be great. Here we go. So first of all, again, thank you all for being here. You know, we named this conference Health Literacy. Next slide, please. Health Literacy in Perilous Times. And there really couldn't be a more apt description of what our situation is right now. If we look at, we are just beginning to emerge from a more than year-long pandemic. We are looking at a world that has uncovered long existing disparities, racial tensions, social injustices. These are not new things. What is new is that thankfully we have these issues now are in our national spotlight and part of our national conversation. We have people who are experiencing economic hardship like we haven't seen in a generation, and social divisions that seem like sometimes they're really going to just rip us all apart. The good thing is that we have an opportunity here to really talk about these things, to try and understand them, and to find those areas that can bring us together. And frankly, one of the things that really is that shared common bond that we all have here is that health literacy as a mechanism, as a way for us to get to a situation of health equity. And that's why we're here, and that's what we're all about. So how does health literacy really help us in these circumstances? Well, it's certainly not a cure-all, but it really allows us to say, we are taking the opportunity as a community to think this through, to really take a hard look at who we are, who are the people that we're serving, and how can we do a better job to understand where they are, what their circumstances are, and how can we walk a mile in their shoes, as they say, so that we can be there to serve the people that we serve that much better. Well, part of that is going to conferences such as this, to establish some connections, to have the conversations that we're going to have over the next 3 days, and especially to ask questions. Those questions are really the most important part. This is how we learn. This is how we understand where one another is coming from. So when we say asking questions, we mean not only here at the conference, but when we leave the conference and when we continue to do our work afterward. And virtually, you know, sometimes that's just as good. I mean, I would love it if we could all be together in the same room, but maybe next year. I think the universe had a little different plan for all of us for this year. You know, we have this notion that people talk about, oh, I can't wait to get back to the new normal, and or you know, get back to normal, or what is the new normal going to look like? And I always worry a little bit about that phrase and that word, because when we say return to normal, we're really talking about trying to recapture something that was and where we were. And frankly, I don't think we have the luxury of being able to do that. We are in a new world. This is you know, we've gone through a transition, and we are in a whole new time and a whole new paradigm. And I think it's really incumbent on us to look forward, to listen to one another, as I said, to ask those questions, and to try and achieve some sort of sense of understanding. So your role is to be a participant here, is to listen, to ask questions, and to try to get to that understanding. And we've really done some hard work on our end and with our conference platform folks to try and enhance the networking capabilities and functions for this virtual conference. And we'll talk about that in just a moment. Rachel, next slide, please. So short introduction about who we are. We're the Institute for Healthcare Advancement. We're a nonprofit public charity. We have our mission initiative is to advance health literacy, to try to get us all toward a place where we can experience health equity. And we've been active in health literacy since 1999. Next slide, please. So I want to tell you a little bit about some of the things that we do. I think a lot of you have probably already seen our Health Literacy Solution Center. I have to say I'm very proud and very happy. We've gone through a months-long reimagining, redesigning of the Health Literacy Solution Center. And I think we have a lot more content in that Solution Center. We have a lot more things to do, ways to connect, ways for you to learn, and ways for you to get involved with the health literacy community. But if you think of the Solution Center as a hub for everybody in the health literacy community to come together, to know what's going on, to connect with one another, to learn, and to advance your own skill set, that's really what we're trying to achieve here. So we hope you take some time and explore. That's at healthliteracysolutions.org, healthliteracysolutions.org. Next slide, please. Oh, and one thing, I'm sorry, Rachel, can you go back one thing that I actually realized is missing from my slide deck here this morning is that I think a lot of you are also part of the health literacy discussion list. And that's moderated by Julie McKinney, who is one of our strategic partners. She has been with us since the very beginning when we took over the discussion list from the National Institute for Literacy, which for some reason the government decommissioned a number of years ago. And she has continued to moderate that, and we're very grateful to her. So now the discussion list not only comes into your inbox, but you can also do a deeper dive and look at those postings from members of the community here on the Solution Center. Thank you. Next slide, Rachel, please. We also publish these What to Do for Health self-help health books. These are written at a 3rd to 5th grade reading level in a number of different languages, all of them in English and Spanish, and a number of other ones in different languages. Next slide, please. We also produce this conference. Next slide. And in collaboration with the Horowitz Center for Health Literacy at the University of Maryland, many of you know Dr. Cynthia Bauer, we also do the Health Literacy in Action Conference. That'll take place October 14th and 15th this year. Again, that'll be a virtual conference. And there's the URL, hlactionconf.com, for you to get details about that. Next slide, please. This is one that this program, I've been actually, if you've been coming to this conference for a while, you know I've been telling you, it's coming soon, it's coming soon. Well, guess what? It's here, yay. The IHA, the Health Literacy Specialist Certificate Program is finally ready to launch. These are 7 assessment-based certificates which in the area of health literacy. And each one of them we call a micro-credential. Altogether, all 7 of those comprise the Health Literacy Specialist Certificate. So back in 2016, we convened a very diverse group of health literacy specialists and asked them the question, what does somebody need to know and what does somebody need to be able to do in order to be considered a health literacy specialist? And so from there, we have been working with subject matter experts, health literacy specialists, with you, the community, with a number of subject matter experts, creating this particular program, and it is finally getting ready to debut right now. So the certificates were built according to standards from the Institute for Credentialing Excellence. The first certificate, Language, Culture, and Diversity, is available now. The rest of them are going to be coming out, the other 6, between now and we hope July, but maybe that might bleed a little bit into August. These are structured, customizable professional development courses. They're online, they're self-paced, lots of multimedia, and there is a final exam with a cut score that you must pass in order to earn that particular micro-credential. We're very excited about this. This is the first thing, anything like it in the health literacy field. And actually tomorrow, one of our certificate specialists who's been consulting with us, Cynthia Allen, and I will have a little chat room available tomorrow on the conference platform. If you have any questions, pop by there. We'd be happy to discuss this with you. Next slide, please. We also publish Health Literacy Research and Practice, which is an online open access peer-reviewed journal. We've been doing this for a couple of years now. I think you know our editors. Michael Pashorlo is our editor-in-chief. Cynthia Bauer is our practice editor. This is available at no cost. All the articles you can get at no cost on our platform and also on PubMed. It's indexed. There's the URL. Or if you just go to Google or whatever your browser is and type in health literacy research and practice, that'll take you right to the journal. We would also like to encourage anybody who would like to consider writing an article about practice, a case study, anything that you're working on, certainly research, but also practice as well. If you're interested in a practice, please contact Dr. Cynthia Bauer. If you need that connection, please let us know and we can make sure we connect you with her. If you have a research project, Dr. Pashorlo is the person to contact. But again, if you have any concerns about how to contact them, please talk to us and we'll get you connected. Next slide, please. Health Literacy Month has been going on for more than 20 years, and this is all the brainchild and the hard work and blood, sweat, and tears of our good friend Helen Osborne. I hope Helen is out there today. She created this, I think it's 21 years ago now. But Health Literacy Month is October. It's a way for us in the health literacy community to really get the word out in general to the rest of the world about health literacy. Hopefully we're doing that the other 11 months as well, but this is a time to really focus on that, to share with one another and to try and really raise awareness around the community about health literacy. And there's the URL, healthliteracymonth.org. Right now is actually a great time to click on that, read up a little bit about it, and kind of get your ideas and your ducks in a row for what you want to do for Health Literacy Month. Again, if you have any questions, please let us know. Next slide, please. A few other initiatives that we do. We have an online community of those individuals who work on the community benefit requirement. These are the hospitals that are nonprofit, and in exchange for not paying income tax, they have to demonstrate a benefit to the community which they serve. This includes doing a community health needs assessment and coming up with a plan as to how to meet those particular community needs. And so this community benefit connect.org site is for all of those healthcare professionals who are responsible for delivering the community benefit. These are actually a great group to work with in terms of health literacy, because health literacy into the community and meeting a community health need is that's a perfect match. And so please feel free to check that out. Next slide, please. So a few things while you're here. If you look on the left side there, you'll note there's different session types, connection cafes. Those will all be tomorrow. Those are a little less formal way to kind of connect on particular topics. You can look at sessions on demand. You can participate in workshops. And we've had a number of pre-conference sessions. Everything is being recorded. So if you miss anything, you can come back and watch that. For the live sessions, it would be the day after. For all the on-demand and pre-recorded ones, you can watch those at any time. Next slide, please. And then networking. One of the things, you know, we had to pivot last year when the world shut down because of COVID-19. And we moved our conference to July. And I think we had a pretty good experience. But one of the things that came through loud and clear was that everybody wanted a little more robust networking capability. And so here, as you can see, are some of the ways in which you can do that. If you click on the networking link there, that'll allow you to do some posting on the social media wall. Our conference hashtag is IHAHLC21. You can video chat with another attendee, or you can contact a speaker. Make sure in your profile you filled out all of your information and let everybody know that you are open to being contacted, because then that way you'll be in the pool of individuals that somebody could click and say, hey, let's go ahead and connect. Next slide, please. And again, here it is. So if you fill out your profile completely and opt in to share your contact information, that'll allow you to direct message or video chat with other attendees, connect with speakers after the session. And if you look really closely, you'll see the person who did this is Diana Gonzalez. Diana is our health education specialist, and I have to give her props here because she is the one who really designed this entire conference experience this year. After about 17 years, I said, I need a little bit of a break. And so she's been working on this with me and the rest of the team for the last couple of years. And this year, it's all her thing. So this is, and I have to say, I think this is probably our absolute best conference agenda yet. So all of the hat tips and kudos go to Diana for this one. Next slide, please. A few housekeeping things. If you have questions about your experience or you're having any problems, there's a virtual help desk at the bottom of the homepage. For your continuing education, please visit the evaluations on the homepage, complete that evaluation, and then you'll get your continuing ed certificate. And again, this session and all the other sessions are going to be recorded and posted within 24 hours. Next slide, please. And you'll all be muted and questions will be addressed at the end of the presentation. You can see the ways to participate there. Type your question in the questions tab. If there's a vote we're asking for, you can move the important questions up. And the discussion tab, again, just type your thoughts and comments. Next slide, please. Okay, great. Now I get to stop talking and give you over to the main show here. And so our session moderator, it's my real pleasure to introduce Dr. Lezlee Matthews. She's a consultant, author, and speaker with more than 20 years administrative, teaching, and research experience. Dr. Matthews holds a PhD in urban planning from UCLA, and she founded her consulting firm in 2020 to help organizations achieve positive social impact. She's president of the Green Foundation Board, a grassroots community health education organization based in our neighborhood here. She's in Santa Ana, we're in La Habra, although we're all working remotely. It is my distinct pleasure to turn the program over now to Dr. Lezlee Matthews. Please, everybody, enjoy your conference, and thank you. Dr. Matthews.
Thank you, Michael. I appreciate that. It's an honor to be here and moderate this session. And it's my pleasure to introduce our speaker for the keynote session, Literacy Tests and the Modern Day Jim Crow, Dr. Ray Block. Dr. Ray Block is Associate Professor of Political Science and African American Studies at Penn State. His research interests include racial, ethnic, and gender differences in civic involvement, the formation and mutability of social identity, campaigns and elections, and other topics. He has published dozens of book chapters, manuscripts, and peer-reviewed journal articles, and is co-author of Losing Power, Americans and Racial Polarization in Tennessee Politics, University of Georgia Press, 2020. He serves as a member of the Executive Council of the National Conference of Black Political Scientists, as a research analyst for both the African American Research Collaborative and Latino Decisions, and as faculty coach for the National Center for Faculty Development and Diversity and for Penn State University's Mid-Career Faculty Advancement Program. Join me now in welcoming Dr. Ray Block.
Thank you very much, everyone. It is a pleasure to be here, and it is an honor to be a part of this great gathering. So, as was mentioned, I'm here to talk about literacy tests and to, if you allow me, draw a comparison between historical aspects of literacy tests and current challenges as it relates to vaccine uptake. Next slide, please. So here's an overview of how I expect this thing to go. So I'm going to spend some time talking about race and health disparities, and I'm going to discuss what I consider to be the dual pandemics of racism and COVID-19. After that, I'm going to discuss literacy tests in the historical and political context that political scientists tend to know them in. And then I'm going to step outside of my area of specialty and talk about the comparisons that I see as a social scientist between literacy tests to vote and what I'm calling literacy tests to get access to COVID-19 vaccines. By the end of this, what I am hoping is that you'll have an appreciation for and be able to identify at least two ways that the current rules and procedures as they are set up today promote inequalities that find themselves dividing across racial groups when it comes to access to COVID-19 vaccines. So if you can think of this as my lesson plan and my course objectives, this is what I'm trying to accomplish now. Next slide, please. So before that, I figure I should tell you all a little bit about how I got into this work, because this isn't a natural area for me. And so I would tell you, if you wanted to think about what my intellectual tendencies are, I'm a social scientist. I study political identity, social identity, and political involvement, broadly defined. Social identity can be gender, it can be race, it can be ethnicity, it can be ability, it can be political party identification. But I care about groups and I care about why groups draw meaning from membership within those groups and what that means the social implications have for that. Now, I usually look at group differences in political involvement. Political involvement can be a lot of things. It could be, for example, whether or not you are paying attention to what's happening in politics. And I did a dissertation on interest in politics. I also look at the connection between social identity and political involvement when it comes to political behavior, whether people vote, for example, whether they donate money to a candidate or to a cause, or whether they protest, right? Now, back when I did my dissertation work, I noticed that roughly around the year of 2008, I got my PhD in 2006, that the racial differences that I typically saw in how interested in politics people were started to shift. Whereas the general story was that African Americans were comparatively less interested in politics than white Americans were. Around 2008, that trend started to reverse. Didn't take me long to figure out that one of the reasons for why that trend started to reverse is because the then candidate Barack Obama was on the political scene. And as a person who wasn't trained in presidency studies, I started looking at the connection between the presidency and the stuff that I normally look at, which is the connection between social identity and political involvement. So I became a presidency studies scholar because I was responding to real world events that were taking place on the ground. That also moved me into thinking about the influence of social identity and political involvement at the state level. During the introduction, I was happy to hear that there was a mention of a recent book that me and a co-author published that is about state level politics, particularly in the state of Tennessee. In that book, we notice a trend that a lot of states are following, and not just states in the Deep South, for example, where states that were swing states or states where politicians from both political parties stood a legitimate chance of winning elections, a lot of those states are becoming solidly Republican preferring states. We saw that in the state of Tennessee, and we did a case study of Tennessee, and we believe that that case study tells us a little bit about the political polarization that's happening across the United States overall. And finally, I look at social identity and political involvement as it relates to police violence. There's a project that I'm working on currently that actually draws upon what we understand about the protests of the summer of 2020 as they relate to injustices related to officer involved shootings, and goes back to thinking about how COVID-19 and the issues surrounding COVID-19 make other social divisions in our society all the more clear. Now, this is me in a nutshell. I figure it's important for you to know how a social scientist like me gets into this kind of work. Like a lot of you, next slide, please. Well, click, please. Like a lot of you, COVID-19 has turned everything upside down. So I come to you humbly to say that my life has not been the same for more than 15 months now because of all of the things that are going on in the world. I've lost family members, I've lost friends. I have changed the way that my routine works in ways that are unimaginable pre the pandemic for COVID-19. And because of that, I am living in this thing as a person who has a family and who has a job and who has all of the obligations that life throws at you, but also as a social scientist. And instead of treating the pandemic of COVID-19 as an extra thing, I decided to lean into this particular curiosity I had about how COVID-19 works, and especially how it works in tandem with the other pandemic of racism that I'm going to be describing today here. So COVID-19 happens, it interrupts a lot of what's happening in my intellectual tendencies, but I just shifted my intellectual tendencies to accommodate what's going on with COVID-19. And this is the reason why I'm here now, because a lot of my work goes from social science into medical research, and I now work with medical researchers and practitioners when it comes to dealing with both the pandemics of COVID-19 and racism. Next slide, please. All right, so now that I've talked a little bit about me, thank you for giving me a chance to do that. I want to now get into conversations with you about race and health disparities and this thing I've been calling the dual pandemics. Next slide, please. Probably one of the lesser known quotes from the late, great Dr. Martin Luther King is this idea of health inequality being something that's really important to address. this should not come as a surprise to the people here and the people in this audience. But for the folks who are in the social sciences, who understand Martin Luther King's contributions to be those into race relations and race relations as they relate to social class, we didn't know that there was a great conversation to be had about Dr. King's understanding of health disparities. And so this quote, I think, is really important because it brings that to the forefront when he says that all the forms of equality, injustice in healthcare is the most shocking and inhumane because it often results in physical death, right? You should know too that this comment was made while King was actually in a conference with medical researchers and practitioners talking specifically about racial disparities in healthcare, which means that King was thinking about how racism intersects with health-related outcomes. And I am now trying to take a page out of that notebook and to follow in that legacy to think about how racism interferes with and interacts with the things that we understand that are going on right now in this health crisis. Next slide, please. So where I come into this is, I believe that if you wanted to theorize about this, you would start at the bottom of the proverbial pyramid. And at the bottom of the proverbial pyramid is my understanding as a social scientist when it comes to racial disparities in society overall. I am not going to make any original claims about that because that's an area of research that has been trod very well in the social sciences. I believe that the connection, though, is that these disparities in society overall contribute to and inform and are informed by racial differences in the impact of COVID-19. And I believe that we should understand the impact of COVID-19 in terms of racial disparities, not only in terms of the health outcomes, the rate at which people are exposed to the virus and the rate at which people become very sick from the virus and the rate at which some people pass away because of the virus, but also in terms of wealth outcomes too. The extent to which people have lost work or have lost wages or have had their job circumstances altered drastically because of the instances that we're dealing with COVID-19. So I believe that understanding racial disparities in our society overall gives us a way of understanding and making sense of the racial disparities that we're noticing in both the health outcomes and the wealth outcomes as they relate to COVID-19. And I believe those things contribute to what I'm going to be discussing today, which will be racial differences or racial disparities. And what I'm going to call vaccine, the word should be uptake. It says access there, but I think uptake is a broader term for thinking about what it is that I'm interested in. And so taking this idea that racism and COVID-19 represent dual pandemics that feed off of one another and that produce things that are synergistically bad. In other words, the interaction of these things is worse than the sum of their parts. I believe that this is a great opportunity for the people on the social science side to have conversations with the people on the medical side, because all of us need to do something to help out with these particular pandemics and the things that stem from them. Next slide, please. All right. So racial disparities and COVID-19 experiences, like I say, this is a pretty well understood research finding that there is this race gap, if you will, between African Americans and white Americans. And my focus today is going to be on those two racial groups when it comes to how COVID-19 affects the health and the wealth of citizens in the United States. In other words, I don't have to see whether or not that is happening. There's research suggesting that this is actually happening. So my question isn't what's going on, but why is it happening? One answer, and I don't think it's the only answer, obviously, but I think one answer is that these racial disparities that we're seeing in the experiences of COVID-19 are a byproduct of racial disparities in health literacy. In other words, to understand why these gaps are the way that they are, I think it's really helpful for us to look at health literacy because health literacy can teach us something about these gaps. Therefore, I believe that addressing issues of health literacy might actually move us in a real way towards understanding and hopefully resolving some of the inequalities that we're seeing in COVID-19 health and wealth related outcomes. Next slide, please. All right, so setting the stage, let's now get to what I was actually invited to talk about, which is literacy tests. And I want to give you a really bad historical overview with political implications to what we should be thinking about when we think about literacy tests. And so As a non-historian, I apologize to the historians and the historian adjacent people in the audience. This will not be satisfactory, but I want to hit the high notes. Next slide, please. All right. So let's think of it this way. We have provisions in our federal constitution to deal with discrimination when it comes to voting. The 15th Amendment is one of several things you can point to that was put ultimately into our Constitution to make sure that this process is more fair. Having something in a Constitution doesn't necessarily guarantee that things are going to be fair, however. And the social sciences in me would definitely say that I am definitely thinking about this in terms of political strategies that were used, for example, to make it so that African Americans, despite these constitutional provisions, have to struggle to exercise this franchise that's supposed to be equally given access to all. And there are some examples of how this looks. And so in the historical context, you can think of poll taxes. You don't see lots of these today, but it's the idea that citizens actually get charged a fee in order to take part in elections. Another one of these tactics is a literacy test where people have to demonstrate their knowledge or competency before they're invited or eligible to take part in voting. Another thing is a grandfather clause where you would actually have to be able to prove that relatives that far back in your family lineage had the ability to vote, because if you couldn't prove that, then the process would be much more difficult for you as a new person coming into the process. These are basically strategies that don't say anything about race. In other words, they don't say, for example, that we're targeting African Americans and making it difficult for them to take part in voting, but the cumulative impact is that they do by indirectly finding ways that makes voting more difficult. They create barriers that are structural and that can also be emotional and psychological. And those barriers have the intended consequence of making voting rates in areas where these types of rules are taking effect more difficult. This should sound very similar because there are current political debates right now about voting integrity and about ease of access to voting, where both sides have arguments that are trying to make connections between this and our democratic process, but thinking very critically about how these movements towards either more access or more integrity can have implications across racial and ethnic groups. Next slide, please. I'm highlighting this because literacy tests are a nice way of thinking about this metaphor that I'm going to be drawing here about the dual pandemic. And so the pandemic of racism creates the circumstances where literacy tests become a thing, right? If you don't want to necessarily single out explicitly African Americans, but you don't necessarily want African Americans to take part in the franchise at the rates that whites do, literacy test is one way to accomplish something like this. The literacy tests that historically we're talking about are things related to your eligibility to vote. Next slide, please. Now, I found this online and I find it to be both funny and sad at the same time. And so there's a news article about some students at Harvard University who basically took versions of the 1964 literacy test. I believe this is the one for Alabama. Don't quote me on it, but it's one of these literacy tests from a steep southern state where people who wanted to cast ballots actually had to prove or demonstrate their civic competence, right? It's hard to see what's on this particular slide on the right-hand side, but for those who can, is these really interesting questions where the questions don't necessarily assess book smarts. In other words, these aren't necessarily the kinds of things that you would be able to answer correctly if you studied really hard. These are like critical reasoning questions that are designed to trick people and to slip people up. If you look at number 25, right, it has in a triangle the phrase Paris in the spring. And I know this because as a kid, this is one of those tricks where most people would miss the second the in that particular saying. And if you missed the second the when you recounted what the phrase was inside of the triangle, you get a wrong answer. And these sort of trick questions are a way of, for example, making it very difficult for people to establish the baseline level of competency that would be necessary for them to say, for example, that I'm eligible to vote. This hurts everyone, but it hurts people of lower socioeconomic status. and people who are racial and ethnic minorities in particular. And again, that was the point. These literacy tests were designed to create disincentives for those people who fall in these vulnerable categories from being able to express themselves through the franchise. Next slide, please. All right. So moving away from literacy tests in the historical and political context, this is an argument that I want to make. I want to say that understanding that stuff contributes to how we understand some of this stuff too. And so I'm going to make this comparison between the literacy test to vote and what I'm calling literacy tests to access to the COVID-19 vaccines. Next slide, please. So from Jim Crow to COVID-19, in other words, moving from a context where we're talking about political outcomes and voting in particular, and barriers that were erected very cleverly to prevent or at least discourage people of color and people from minority and demographically disadvantaged communities from taking part. I see a logic that carries over to both. And there are lots of ways to me that the logics carry over, but here's a handful of ways that I see the logic carrying over. What do they both have in common, if that's the question? One of the things that they have in common is they create structural barriers. Rules are structures. Rules represent the things that take place in institutions. And if there are, for example, literacy tests of voting, that means that you have to be able to get around those rules or to achieve, despite the rules, in order to take part. There are some structural characteristics to what's going on when it comes to access to information about COVID-19 vaccines and access to the vaccines themselves. And I think that makes the logic and overlap here. Also, the reason why these things work is because they exploit misinformation and even disinformation. So when I say misinformation, what I mean is sometimes the information itself isn't accurate, but it's not in a malicious way, right? Sometimes things just simply aren't correct and you don't have to necessarily make a value judgment about the incorrectness of the information. Other times the information is deliberately deceptive in the sense that the information is put out there to create confusion and or to create an outcome that goes contrary to what accurate information would give you. So I think misinformation and disinformation are really important things that are happening right now. Also, as an apology, I'm at home, so if you hear any noises in the background, it's homeschooling. All right, so in addition to these tactics for literacy barriers, using misinformation and disinformation, I will just say that the cumulative impact of this is that it can be discouraging. A person who is fed disinformation or misinformation might find it harder to get to the outcome they're trying to get to. A person who's seeing structural barriers in front of them might find it harder to get to the outcome that they're trying to get to. The same way that these things are in a position to make it difficult to vote, for example, they can also make it difficult for people to navigate the process of getting the vaccine. And if I'm of the same mind as some of the people in this audience, the last thing we want to do is create these barriers and to create these disincentives for people getting the vaccine. Next slide, please. All right, so here's some information. I'm using a survey that was recently done this year, a couple of months ago. It's from Axios and Ipsos, and it's a coronavirus index poll, and this is the 42nd wave of it. The fact that we're at wave number 42 now for these polls is actually unsettling because that means we're still dealing with the coronavirus vaccine and coronavirus pandemic, right? Now, one of the things that I noticed in my own research is that one of the ways that you can look at literacy and inequalities in literacy is you can look at inequalities in the impact of what I'm going to call information accuracy, right? And so I have these questions here. A lot of these are the kinds of questions that sort of reflect the conspiracy theories about getting vaccinated, which means that there are right answers and wrong answers to whether or not, for example, the coronavirus vaccine can promote cancer, or if there's a microchip inside of the vaccine that's going to be used to track the people that get it. Now, you don't see a lot of people falling for that. In other words, if you look at the number of people that say this is true, it's usually very small. That's a pattern you're going to see throughout this, by the way. There are a handful of questions from the survey that get at these conspiracy theories. I'm not necessarily concerned with the people that believe it's true. I'm concerned with the people that don't know, right? Because in a world where there is conflicting information about the vaccines, seeing, for example, that roughly half, close to half the African American, like over 40% in those cases, of the African Americans are not sure whether or not the messenger RNA in coronavirus vaccines is cancer producing, or that there's a microchip inside of the vaccine that once you get, it's going to keep track of you, right? The fact that folks don't know whether they have that answer right or wrong is the thing that's most concerning. And this is a pattern that I want to show you throughout these slides. So here are two of those questions in the poll that get at these conspiracy theories that to me look at misinformation and disinformation. Next slide, please. Here are two more. So this is one about whether or not getting vaccinated is going to disqualify you from life insurance benefits. Another one of those things that you hear people talking about in communities and online. And again, the don't knows, like I want to make sure that I'm not necessarily concerned with whether or not people know it to be true or false, but whether it creates doubt in the idea about whether or not a person could or could not get disqualified from their insurance benefits if they get vaccinated is an issue. Likewise, the idea that some people believe or not believe that the Johnson & Johnson vaccine contains stem cells is an issue. But the fact that some people don't know if that's a rumor or if that's true is an issue. And the fact that we know that the current versions of the vaccines that are out in circulation don't include stem cells doesn't change the fact that if you look at the African Americans in the sample, 41% were concerned about whether or not, or not really sure about whether or not the vaccines do or do not have that in them, right? That's part of this issue. Next slide, please. This is the last of the set of conspiracy theory items that this particular poll has. But the last two that I wanted to consider is whether or not the vaccine sterilizes recipients from a reproductive standpoint. And the don't knows again are pretty high. Likewise, people who believe the vaccine is more deadly than the virus itself. The numbers of people who know that statement to be false is encouraging, but the fact that the don't knows are as high as they are speaks to this general idea that misinformation and possibly disinformation is a real problem, because if a person's on the fence when it comes to these sort of ideas about what would happen to them if they get the vaccine, it makes it that much more difficult to convince people to get the vaccine. And so the literacy angle that I'm giving here is really about access to information that is accurate and not misleading, that people can feel confident in when it comes to making a decision about getting vaccinated. Next slide, please. All right. So we talked about information related reasons for me to be concerned about vaccine uptake and how that goes across racial groups. Let's now look at some literacy-based reasons for hesitancy. There's a question in the survey that I think gets at this, and it asks basically what has made it difficult for you to get a vaccine. In other words, it figures out who has been vaccinated or who hasn't because they ask a question on the poll, and they take those answers to be the truth. We can debate whether or not that's the best way to measure vaccine hesitancy or confidence all day, right? But from the survey, there's a follow-up question for the people that say or claim that they haven't been vaccinated. And that question is, what's standing in the way? Why is it difficult for you? What is it that you can point your finger to that's making it difficult for you to get vaccinated? And there are two particular responses to that item that I think are very useful here when thinking about reasons for hesitancy that are literacy based. So one reason might be a person simply doesn't know how to get the process started. They don't know how to get vaccinated. And there's not many respondents in either racial group that are expressing this, but it's more than a quarter of the respondents that are doing so. There's not a descriptive racial difference here, and I would be very cautious about making any claims about statistically significant differences anyway. All of this is descriptive and all of this is illustrative at this point. But the idea that a substantial number of the respondents in this particular survey say it's difficult to find out how to make an appointment gives me an idea that there's something about the process, or at least something about their belief about the process, that's actually standing in the way of them getting to the outcome that they would possibly want to get to, or it's preventing them from seeing this as a viable outcome. And so if you're like me, if it's hard to do stuff to take care of yourself, then sometimes you don't take care of yourself. Sometimes you don't get the vaccine because you can't navigate the labyrinthine process that you need to go through in order to get yourself an appointment, or you don't even know where to start. Those things to me represent gaps in our ability to say that there's widespread literacy when it comes to vaccine uptake. And the fact that the African Americans in the survey sample are outnumbering the self-identified white respondents in the survey when it comes to people that are particularly expressing this concern, the concern about the difficulty of making an appointment, speaks to some of the worries that I have and speaks to some of the things that I wanted to mention to you during this presentation. Next slide, please. All right, so that's it. I hope this was helpful. I hope this is useful for the broader conference and for the broader conversations that are going to be happening here. And I just want to thank y'all again for letting me be involved. Thank you.
Thank you so much, Dr. Block. I'm going to ask you to come back at the end of the session to join the Q&A. I'm sure folks will have a lot of questions for you. Very provocative information. But I'd now like to transition to our next presentation, Health Literacy in Support of Equity, Removing Barriers to Increase Access to Care. Let me introduce you to our panelists by reading their bios. After all three have presented, we will have our Q&A. So please listen carefully and add your questions to the Q&A. The first panelist, Emily Brunson, PhD, MA, is an applied anthropologist specializing in medical anthropology who received an MPH in epidemiology and a PhD in anthropology from the University of Washington in Seattle. Her research focus is healthcare access and decision-making, particularly how policies, social structures, including class and racial inequalities, social networks, and personal experience all combine to produce health outcomes for individuals. Currently, she is developing research plans and conducting policy outreach in relation to COVID-19 vaccination with colleagues from the Johns Hopkins Center for Health Security. And Dr. Brunson is working on a study of COVID-19 vaccination knowledge, attitudes, and behavior among college students. The second panelist you'll hear from is Dr. Jacinda Abdul-Mutakabbir, PharmD, affectionately known as Dr. Jam, and she is currently an assistant professor at Loma Linda School of Pharmacy in Loma Linda, California. She completed her doctorate in pharmacy at the University of St. Joseph School of Pharmacy, located in Hartford, Connecticut. Following pharmacy school, she completed her pharmacy residency at the Howard University Hospital in Washington, D.C. She also completed an infectious disease, pharmacokinetics, pharmacodynamics research fellowship under the tutelage of Dr. Michael J. Ryback, and went on to earn a Master's of Public Health at Wayne State University in Detroit, Michigan. She is dedicated to magnifying and rectifying health inequities in minoritized communities. To that point, Dr. Jam currently serves as the lead pharmacist and clinician for the Loma Linda University COVID-19 Equitable Mobile Vaccination Clinics. And our third panelist, Dr. Jerry P. Abraham, MD, MPH, CMQ, is a Harvard, Emory, University of Texas, University of Southern California trained family and community medicine physician. He is a global injury epidemiologist and a medical quality specialist caring for patients in South Los Angeles at Kedren Health, an historically Black institution, which includes an acute psychiatric hospital with an outpatient mental health program with field-based work, and a federally qualified health center, patient-centered medical home primary care clinics. He serves as the director of the Kedren Vaccines Program, which is committed to vaccinating a high volume of patients against COVID-19, equitably distributed and administered, with accurate and timely reporting back to various jurisdictions, including the California Department of Public Health. From Kedren 1.0 in South LA, he and his team vaccinate over 2,500 people per day. And to date, they have vaccinated over 250,000 people from the community, removing every barrier standing in the way of Dr. Abraham's patients and their vaccine. So I will now turn it over to our first panelist, Dr. Brunson.
Thank you. It's a pleasure to be with you today. And I was very excited to hear Dr. Block's talk and to listen to the other talks in this session. So the focus of my presentation is on equity in vaccination and how communities can really work with people of color towards COVID-19 recovery and to use COVID-19 vaccination as a mechanism to create lasting change in terms of health equity. So next slide, please. I'd like to begin by talking about COVID-19 vaccine uptake. So vaccine uptake is a term that gets thrown around a lot, but as Dr. Block pointed out, it involves both the intent that a person has to get vaccinated and then their ability to access the vaccines. Considering intent is usually the most common approach, and when people talk about this, especially in a US context, it's sort of the thing that people think that if there isn't the uptake, that it must mean that somehow people don't want it. But even that idea of intent can really be broken apart into, it can be belief and or trust in vaccines, meaning that you believe in the science, you believe that vaccines are good for you, or you don't. But then also belief in or trust in the system. So with the idea that medicine, public health, the government works for you, you can trust what it is that they say, or you can't. And so that gets more complicated, and we'll get into why and how that can be rectified in just a minute. But I really want everyone to consider access. Access is a big issue. What people end up with in terms of vaccination outcomes is not always a matter of choice. You could have people who are absolutely willing to be vaccinated and cannot do so. And this is true even in the US, and definitely with what's going on with COVID vaccine today, we see some definite evidence that access is a major issue for some communities. So next slide, please. So I'm taking this from the New York Times article from May 12th, 2021. And if you're looking at this graph, what you'll see is that on the left hand of the graph, which is the first quartile of counties, those that are economically better off have a much higher uptake rate. The second quartile, it's more what is closer to the average, but still a decent uptake rate. But then when we get into the third and fourth quartile of counties that have disparities and where there's some economic disparity going on, the COVID-19 vaccine uptake really drops off significantly. And this is suggesting very strongly that there's something about access going on. So next slide, please. So thinking about this, there are many access issues that can actually occur. In the research that I'm conducting now as part of CommuniVax, not knowing how to get a vaccine is a significant issue. Some states like West Virginia did a fantastic job of having a centralized, this is where you go to sign up. But other states, including Texas, where I'm at, it's very confusing for many people to understand how to go about getting a vaccine. There can be sign-up issues. And this is particularly true if you're dealing with low-income persons or people who don't usually use the internet, if all of the signups are online. And so this also affects older adults. There can be a lack of transportation to vaccination sites. And even though there are opportunities through organizations like Lyft and Uber to get free rides to vaccination clinics, what happens if you don't have the internet connection or a smartphone to be able to set that up, or you don't know about it? So that's been an issue in some of the communities that we're working in. Not being able to take time off from work, with having vaccination sites that are only open during work hours, and you have people who are marginally employed whose work will not allow them to take that time. And what happens if you have a bad reaction to the vaccine and you're sick for a day or two? So that can be a problem. immigration status, if you're not in the country legally, or even if you are, if you're worried about coming under the scrutiny of ICE or other government organizations, that can also be prohibitive. And these are just a short list of different access issues that we're seeing in real time across the US today. Can you hit the next button, please? So when we're talking about equity here, and this is important to note, that when we're talking about equity, we're making things equal, not just making sure that, that everyone's sort of bumped up, but it's really making things equal. So the definition that I like to use for equity in vaccination means that in any community, if you were to pick the person that was the most vulnerable or marginalized, is the COVID vaccine easy for them to get? And if the answer is no, then things need to be addressed. So next slide, please. This is what I'm going to primarily focus on today, and specifically going towards the need that exists in BIPOC communities. And Dr. Block already did a wonderful job explaining what's going on in these Black, Indigenous, and people of color communities. COVID-19 has disproportionately impacted these people. There are higher rates of disease, hospitalizations, and death. They're more impacted by the social and economic upheavals caused by the pandemic. And this is particularly true in low-income areas, which many BIPOC persons do live in low-income communities as well. So that's further exacerbating the situation. So there's a great need for this issue of equity to be dealt with in terms of COVID-19 vaccination and other health issues. So next slide, please. So today I'm going to focus the rest of my talk on the research that's coming out of CommuniVax. So I'm the co-lead for CommuniVax, which is a national coalition to strengthen the community's role in an equitable COVID-19 vaccination campaign. As you can see at the map on the right, we have research sites across the US. There are actually 2 in Maryland. There are 3 Hispanic sites and 4 sites with Black populations. So can you hit the return button again? The specific detail that I'm going to be drawing upon is from our first national report, which was released last February. We're getting to the point where we're going to be releasing another in about a month, but for right now, we'll deal with the February one that is currently published. So this report was designed to give elected and appointed officials the tools to create, implement, and support a vaccination campaign that works with BIPOC communities to remedy COVID-19 impacts, lay the foundation for unbiased healthcare delivery, and enable broader social change and durable community level opportunities. In the next 5 slides, and for the rest of my presentation today, I'm going to review the 5 key principles that were identified in the report. The full version of the report, as well as associated quick start toolkits, are available on the CommuniVax website. And I included the URL on the left of the slide. So next slide, please. So this is a quote that came from one of our participants in a Black community in Maryland, pointing out that the reason why she was really concerned about COVID and did not want to get the COVID vaccine is that she had been worried and wanting to get issues about diabetes in her community addressed for decades, and nothing was being done. The public health department, the government, everyone was uninterested in addressing this issue in the Black community. And so she had a lot of trust going on with, why do they care about COVID now? And seeing this as more as the way she put it, this is a white person problem, and really a lot of distrust. In order to address this type of issue, it's important that repeated engagement with BIPOC communities occurs. Now, many people in public health are feeling a pressing need to get as many people vaccinated with COVID-19 vaccines as possible. But it's important that this urgency be balanced with the need to build real trust in BIPOC communities. So how can this be started? We offer 3 suggestions in the report. The first is that the engagement must be both short-term, so you can address COVID-19 vaccination, but then thinking about this as what are you going to do long-term, and especially addressing other issues of importance to the community, especially if they've been long-standing. It's important to assemble a durable infrastructure to engage BIPOC communities and engender their trust. And part of that means that you begin to work with BIPOC community members instead of going in and saying, this is what we need to do, this is the plan, to really listen and to begin planning together for what can be done now and in the future. So next slide. Our next key point is involvement. Moving forward, BIPOC community representatives and advocates must become active collaborators in the public health process. And that needs to be facilitated in many cases. So the way that this can be facilitated can involve implementing mechanisms for two-way communication that can be done through this process. So first, mapping the social landscape of BIPOC communities. So understanding, who are members of your community and where the commonalities and differences. It's very important to not assume that just because you have a Hispanic population, for example, that everyone is the same and has the same set of beliefs and the same social networks. So it's really understanding and talking to people about where they're coming from and how people are connected. Secondly, designing a task force and decision-making bodies that are representative of the broader community. So this does include BIPOC persons and community organizations if they're not already involved. And then to really empower BIPOC individuals and groups as partners, once again, not as subordinates to instruct. And looking on the right of the slide, the logo is small, but an example of this being done currently comes from San Francisco, where groups like the Latino Task Force have been able to leverage their longstanding involvement in the Hispanic community to help facilitate COVID-19 testing and more recently vaccination. So next slide, please. So third is the point of information. Effective communication is essential, but communication is more than messaging, as the quote on this slide points out. So when it comes to health literacy, it's explaining to this in a way that, it's going beyond just I'm talking to you, I'm actually listening. So effective communication can be done as we apply lessons learned from these listen and planning sessions, that you take what community members have been talking about, that you listen to those and that you act on what was discussed. Supporting trusted BIPOC individuals and organizations who can effectively relay information and help set community norms will be important. And then finally, exploring all avenues to provide information that is reliable, meaningful, culturally relevant, and actionable. And this is important because sometimes as people, especially if the public health practitioners, if government officials are white and middle class, the ways that you would communicate may not be the ways that other people are in the community are sharing information. So for example, in our Idaho community and actually in Alabama as well, with Hispanic groups, the radio stations are actually the key way to share information, which was something that the public health planners had not realized until that was pointed out to them. So next slide, please. Okay. All of the efforts that we discussed so far require investments of time, attention, and funding. At the same time, the vaccination process itself really needs to be viewed as an opportunity for economic revitalization, with the potential to lead communities out of the pandemic and its economic hardships. This type of revitalization is particularly important in BIPOC communities that historically and presently are often economically challenged. So practical suggestions for investment include pulling together necessary resources to ensure that the COVID-19 vaccination is equitable, and then fighting to keep those resources in place moving forward. This can be done through creatively financing nonprofit and for-profit entities within the BIPOC community to strengthen the vaccination enterprise, can be done by enlisting the help of private capital to support vaccination. For example, by getting even local transportation companies to commit to providing free rides to vaccination sites, or by having something like a local grocery store sponsor a Get Vaccinated poster contest for school children. So next slide, please. Finally, the last point in the report is integration. So the idea here is that recovery from COVID-19 will take time. COVID will have long-lasting physical, psychological, and financial effects, especially for people in BIPOC communities. Because of this, the COVID-19 vaccination campaign cannot be viewed as a final step in returning to normalcy. Instead, it really needs to be seen as a step towards a more complete recovery that can and should include meaningful social change. This can all take place as the recommendations that I outlined on previous slides, including listening and plan sessions, empowering BIPOC individuals and communities, and investing in equitable public health, are integrated into ongoing community initiatives, and as government and public health officials commit to ensuring durable social change and community benefits that include adequate housing, food security, living wages, and leadership opportunities. And I do appreciate that this approach is challenging and that it will be challenging in many communities. Some may argue that a lack of time or funding or interest are barriers that would make such an approach unrealistic, especially in the middle of a pandemic that is challenging on every front. However, it's important to keep in mind that challenges like the one we are currently facing often stem from social inequity and provide opportunities to change and improve. Some actions may be more appropriate to prioritize in the near term, but many actions that are crucial for the long term will have more of an overall impact if those efforts are initiated now. COVID-19 vaccination is the most likely way out of the current pandemic. It is also an opening to create equity and durable benefits for BIPOC communities who have been devalued and too often cut out of opportunities in the United States. So I hope that you'll consider these points and the specific recommendations that I've shared with you today to begin to implement COVID-19 vaccination campaigns in your own towns, cities, and states. Thank you.
This presentation, you all should be able to describe the interrelationship of structural racism and health equity, identify the appropriate stakeholders necessary for conducting community vaccination clinics, and then finally listing the proper strategies involved in engaging racially and ethnically minoritized groups in COVID-19 vaccination efforts. Next slide, please. So I usually go ahead and I talk about, just the importance of, or how racism attributes to what we see here with COVID-19 and race in minoritized groups. However, I will say that Drs. Block and Brunson did a phenomenal job describing that. So I'll go ahead and I'll just go and talk about this photograph here that we have on the right. So here we really see just that difference between health equality and then health equity. So with equality, we see everyone here has a bicycle. So we see that individual there in the wheelchair has a bicycle. We see that individual there. We see a taller individual with a bicycle. We see a shorter individual with a bicycle, and everyone has a bicycle of that same size. And then we see when we talk about equity, we see everyone has a bicycle, but that bicycle is fitted to everyone's specific needs. So this is just that difference when we get to health, when we talk about health equality and then health equity. So health equality is everyone being given the same thing. So everyone being able to have access to these COVID-19 vaccines when we think about this in the respect of COVID. But health equity is those COVID-19 vaccinations being fitted, or actually receiving those vaccines being fitted to everyone's needs. So let's, next slide, please. Let's put this even more into perspective. COVID-19 is just that perfect example for truly viewing how healthcare how healthcare inequity has permeated through minoritized communities. First and foremost, Black, Latino, and Native Americans represent a combined 60% of COVID-19 deaths, despite comprising significantly less of the United States population. To put this even more into perspective, Black Americans represent 13.4% of COVID-19 of the United States demographics. Native Americans represent 1.6% of the United States demographics. Nevertheless, they are comprised in the 60% of COVID-19 deaths. However, systemic practices have placed them at this disadvantage for access to healthcare. So the morbidities that we know to be associated with increased death for COVID-19 are very much prominent amongst these groups. The vaccines are available. However, a long history of mistreatment within the United States healthcare system decreases their trust for these practices. Therefore, these groups are less likely to get vaccinated, which increases COVID-19 related deaths. For those that do want to be vaccinated, we then run into that fear of costs associated with healthcare that keeps them from being vaccinated. Also, there has been an extreme lack in vaccines allocated to these communities, as Dr. Brunson so eloquently described, or inconsistent computer-based signups, which make Wi-Fi mandatory, which once again continues to magnify the digital gap that we have in terms of vaccination access. So I want to bring you guys back here to Southern California and talk about what we have at Loma University right here in San Bernardino County. So we've currently vaccinated about 30 million individuals here in California. They've received at least one dose of these COVID-19 vaccines. And at Loma University, we have the largest mass vaccination clinic site in San Bernardino County that is called the Drayson Center. So San Bernardino County is the second largest county here, is the largest county or second largest county in Southern California, second to fourth. This Drayson Center is located in a suburban area. This suburban area has a decreased transportation system, and it has an entirely online registration base. We vaccinate anywhere from 1,000 to 1,900 individuals per day at this mass vaccination clinic. Nevertheless, in this clinic, only 3% of vaccinees, or a little bit over 3% of vaccinees, have been Black individuals. This is paralleling what we currently see in the state's demographic of vaccinees, COVID-19 vaccinees. Nevertheless, it is far less than the burden of COVID-19 amongst the Black community. Next slide, please. So here at Loma University, to have a more concentrated effort for vaccinating the Black community, we've developed a more targeted approach, or a tiered approach. With this, we established 3 tiers. Those include 1, the engagement of Black faith leaders. Secondly, the delivery of COVID-19 vaccination and education from a Black pharmacist. And then thirdly, we created low barrier vaccination community clinics that have been held right within targeted Black communities. Next slide, please. So the engagement of Black faith leaders, or Black faith leaders, have been shown to be a major role and have been shown to have major roles within the Black community. This has been shown to be abundantly clear in regard to COVID-19. Also, the Black faith leaders are intimately acquainted with the burden of COVID-19 amongst their parishioners and their communities, so they are interested in overcoming this virus. So in San Bernardino County, we have 2 organizations here, the Inland Empire of Concerned African American Churches, ICAC, or the Congregations of Organized for Prophetic Engagement, or COPE. These organizations have comprised of about 20 churches within the San Bernardino County and Riverside counties of Southern California. It took a lot of convincing on our behalf to engage these faith leaders, and Loma University is a faith-based organization, so we do have standing relationships. Nevertheless, it was important for us to explain to the faith leaders just the importance of COVID-19, the importance of the vaccination, and to make it clear that we were serious about the relationships that we were creating with these faith leaders in terms of getting these vaccinations out. Nevertheless, these pastors have been integral and imperative, and above all, essential in disseminating the information required to be vaccinated. They have organized sign-up lists, they have designated sign-up sheets, and they have provided pop-up tents, chairs, and tables for these vaccination clinics that we hold. Also, we have conducted each of our COVID-19 vaccination clinics that are within these Black communities at one of the churches of the pastors that are affiliated with these two COPE and ICAC organizations. So going to our talking about this engagement of the faith leaders, next slide, please. I want to discuss the COVID-19 faith summits that we do have here at Loma Linda University. So we conduct these faith summits as a way to engage the Black community as a whole. We have culturally representative individuals or panelists that serve as our speakers here at these faith summits. We begin with Dr. Juan Carlos Villaire, who is our Assistant Vice President for Community Engagement at Loma Linda. Then we have Dr. Bridget Petit, who is a Black psychologist that talks about the fear of getting vaccinated and just the importance of vaccinations and how it differs in terms of what we think about when we think about the Tuskegee Airmen, when we think about the Tuskegee experiment and how that relates to COVID-19 vaccinations, and describing the difference between the Tuskegee experiment and then the Tuskegee Airmen, which is something that needs to be made abundantly clear in the Black community. And then myself, I am an infectious diseases trained pharmacist, and I describe the pharmacology of the COVID-19 vaccines. And I also talk about just the clinical representation of the minoritized communities within these clinical trials for the COVID-19 vaccinations. So we are very comprehensive with these COVID-19 faith summits. We have about 100 to 200 attendees per summit, and we conduct these prior to us having the COVID-19 vaccination clinics. However, Dr. Bridget Petit, she conducts surveys. She has a pre and post survey to see how many individuals are we able to engage within these faith summits and how many individuals are we able to bring to that vaccination side. So before we begin the summit, before these individuals have received any information, we have about 50 to 70% of individuals that check yes in that box of they are interested in being vaccinated. Then when we conduct our post surveys, we show that we're able to increase that 70% to about 90% after we give them information pertaining to those vaccines. So that just goes to show the importance of these faith summits. Let's go ahead to the next slide, please. The discrimination and mistreatment of Black individuals is heavily ingrained in the consciousness of the Black community and in the fabric of the United States identity. To that, we are really seeing the result of years of mistrust, and to rebuild these cultural relationships, it is important that we do have representative individuals that conduct these informational sessions in regards to the vaccines and build these constitutions and institutions of trust within these communities. Not only that, but racial and ethnic concordance has been shown to increase patient outcomes. So now is the time that we utilize Black practitioners that are knowledgeable about various subjects pertaining to these COVID-19 vaccinations. So as I previously stated, I am an infectious diseases trained pharmacist, and I am bench trained, meaning that I do in vitro research. So I've been able to use some of those skills that I've acquired during my additional training to explain the COVID-19 vaccines and clinical studies thoroughly. So I've dedicated myself to doing just that. In addition to the faith summits that I conduct, I also provide presentations to various organizations within the San Bernardino County, as well as to individual churches, so that we can increase the amount of individuals that do come and get vaccinated at the clinics that we do have. Next slide, please. So as I stated, I have given information, and I've created just that role of trusted messenger within the San Bernardino County when we have these vaccine clinics. However, I do also manage the vaccines that we do have at those vaccine clinics, and the individuals that come to that clinic, they know that. So it's important that that you do have someone there that is culturally representative, because we do have questions of, am I getting the correct vaccine, or am I just receiving placebo? And I'm able to offer a reassuring face and to allow for them to know that they are receiving exactly what it is that we said they're receiving. And I'm able to answer questions in the event that we have individuals that have questions pertaining to the vaccine, and those questions that pertain to the vaccine that are directly racially related. Next slide, please. We've also created a low barrier community vaccination clinic. So several barriers to vaccination, which other presenters have eloquently stated, are access to actually having those vaccines, transportation, being able to get to those vaccine clinics, and then internet computer access, meaning being able to register to receive these vaccines. So here I have this sheet of paper in this photograph. However, this is what we use for our Loma Linda University community-based clinics. we have a paper-based registration. So this paper has all of the information that would be needed to register individuals for the vaccine and to upload all of this information into the California Immunization Record Space, and to also create profiles for those individuals that we vaccinate. However, it takes away that barrier of individuals having to have access to the internet or the computer to go ahead and register for that vaccine. We also hold those vaccine clinics right in the community. So right there at the churches that are well known amongst the community. And typically those individuals are able to get to receive the vaccine. Also having this paper-based registration, in addition to having this very comfortable format for the vaccine clinics, you kind of take away that, oh, well, I'm nervous to get the vaccine, or should I sign up, or shouldn't I sign up? Because you see your friend or you see your cousin who's gotten vaccinated there before you. You see individuals from the church that actually assist us in that. So creating this low barrier format for the clinics are definitely attributable to the success that we've seen with the vaccine clinics. Next slide, please. We have various stakeholders within these clinics. I cannot stress enough just how important the faith leaders have been to the success that we've seen with the clinics. We also have pharmacists, so myself, and then colleagues in the Loma Linda University School of Pharmacy that assist us with making sure that these vaccine clinics go according to plan and that the vaccines are drawn appropriately. We also have additional pharmacy staff, so our professional students have really been integral in what we have here at the vaccine clinics. We have other medical professionals, so physicians, nurses, dentists, respiratory therapists that assist us with vaccinations. We have a very multidisciplinary effort. We also have community health workers, which give us a lot of access and insight into these communities that we are vaccinating, as well as church volunteers. That representation is very much helpful to those individuals within the churches that we do vaccinate. We also have administration personnel who assist with ordering and making sure that the vaccine clinics are very much streamlined. And then we also have supply chain management who assist us in ordering the necessary tools for the vaccination clinics. Next slide, please. I also like to discuss just the format and the workflow of our vaccine clinics. So the vaccine clinics are conducted either indoors or outdoors, and we have a similar format for each clinic. So we have the registration area. This is occupied by 4 individuals. They make sure that that sheet that I showed you all is filled out appropriately. Following that, we have a community health worker that then directs individuals to proper seating areas where we have about 4 to 6 vaccinators, those vaccinators typically being professional students. Those individuals then go to a waiting area for the 15 minutes, and then they're observed by another healthcare professional, whether that be a pharmacist, EMT, nurse practitioner, or physician assistant. So this is our workflow for our low barrier vaccination clinics. Next slide, please. We, of course, have measurable outcomes because it's important that we're able to quantify what it is that we're able to do at these vaccine clinics. So we've conducted 2 Moderna clinics in the Black community, and then we've had 1 Johnson & Johnson vaccine clinic in the Black community. So here I have our first clinic. So within a 1.5-2 month span at the Drayson Center, the mass vaccination clinic effort, we have vaccinated about 17,000 individuals. However, only 3% of those individuals have been Black. Then when we conducted our first mobile vaccination clinic, we vaccinated 420 individuals. 351 of that 420 individuals have been Black individuals. So 83.5% of our vaccinees were Black individuals. We've continued to increase the numbers and the amount of Black individuals that we've been able to vaccinate with our community effort. Next slide, please. I cannot detail enough just how important it is to have our students a part of this vaccination effort. We have professional students ranging from medicine, pharmacy, dentistry, respiratory therapy, nursing. These students have really been able to be on the ground and a part of this equitable effort. So therefore, we are training more empathetic-minded and equity-minded practitioners, which will be very important as we think about the long-term and the longevity of these projects. Next slide, please. We have begun to reproduce these community vaccination clinics also amongst the Latino community, and because they are also disproportionately represented amongst COVID-19 mortalities and a decreased representation when we think about vaccinations. So in our first Moderna clinic that we conducted within the Latino community, we vaccinated 258 individuals. In our second dose follow-up clinic, we vaccinated 253 individuals. So we had a 97% return rate within this community. So we've really been able to just optimize the efforts that we utilize when vaccinating the Black community and then translate that to other minoritized groups. Next slide, please. Nevertheless, we have definitely noticed differences within these barriers, within these communities. So in the Black community, we can see that we have about the same amount of Latino individuals that we are vaccinating when we go into the Black community. Nevertheless, when we go into the Latino community, we do not see that same representation amongst Black vaccinees. Therefore, we do know that it is a difference in barriers amongst these communities, and we have to make sure that we acknowledge this and address the difference in barriers that do exist. Next slide, please. We also hope to continue these efforts long-term. We hope to translate the efforts that we've seen with COVID-19 to also talk about other disease states, including influenza, shingles, HPV. We've begun disseminating information in regards to HIV PrEP. We want to make sure that we are able to fight other diseases that are represented more so in minoritized groups. Last slide, please. I want to conclude with health inequities are a product of structural and systemic racism. So we want to make sure that we are optimizing equitable processes to deliver positive patient outcomes amongst these minoritized groups. And finally, providing these equitable approaches are definitely going to require multidisciplinary support and collaboration of multiple groups. Thank you so much.
Thank you, Dr. Abdul-Mutakabbir. We really appreciate your perspective. Our last panelist, but certainly not least, is Dr. Jerry Abraham. Welcome, Dr. Abraham.
Hello. All right, roll clip.
Not happening that way everywhere. It's not the same problem. It's not that bad everywhere. There are places that can show us the way. This is Kedren Health, located about 20 minutes down the road from Linwood, that pocket of LA I talked about earlier, the one that's been hit so hard by COVID. Kedren serves that neighborhood, Linwood, as well as other poor, densely populated, predominantly non-white neighborhoods in the surrounding area, all areas that have been disproportionately crushed by COVID. Now, in normal times, Kedren is mainly a mental health clinic. It was founded in the 1960s after the Watts riots in LA to bring psychiatric care to an underserved community. These days, though, Kedren has become a COVID hub. Access to testing and vaccines brought to that neighborhood and to the neighborhoods that Kedren serves to make sure that those neighborhoods are not overlooked by the health system, which did almost happen to the community served by Kedren. This is amazing. This is Dr. Jerry Abraham. He's a family doctor and epidemiologist working at Kedren Health. And he says in December, when the FDA first approved the COVID vaccines, the health department just never called Kedren, never called his clinic to set up their deliveries of the vaccine. So eventually he picked up the phone and gave them a call to ask where his clinic's vaccine allocation was. Turns out Kedren had just slipped through the cracks. The health department had forgot to allocate vaccine for Kedren. But he called and made it right. And they fixed it right away. And Kedren Health now has the vaccine. And yes, it's nuts that Dr. Abraham had to surmise that on his own and call them and get them to fix that to get his hands on the vaccine. But what he's doing with it now that he has it, that's the real story here. And that's potentially the real template for clinics like his around the country. Dr. Abraham is in charge of vaccine distribution at Kedren Health. He's doing it in a way that makes sure the vaccines are given out equitably, that vaccines in a predominantly Black and brown community are going predominantly to Black and brown people. And to make sure that happens, Dr. Abraham has deliberately, consciously, carefully stripped away some of those barriers for entry we just talked about to make sure the vaccine he has gets into the arms of the people in his community who need it most, so that they're not held back by artificial barriers to entry. If you don't have the internet, don't have a smartphone, it's okay. At Kedren, they will hand you a piece of paper and a pencil to register for the vaccine. Even if you can somehow get to a computer or a smartphone, but you're not that comfortable using it, you're not that great with technology, no problem. At Kedren, a volunteer will take the time to input your information online for you. They will sit with you and get it done. They will operate the machine if you are not comfortable doing it. Don't have a car? At Kedren, you do not need one. You can walk up and get the vaccine on your own 2 feet. What Dr. Abraham and his colleagues have designed here, what his health center is doing is working. And it should be seen as a national model at a time we need one, and fast. Kedren has vaccinated about 15,000 people since December. Almost all of them are people of color in a community that is almost all people of color. Unlike in most parts of the country, if you took a snapshot of the people that live around Kedren, the demographics of the people who live there actually match up with the demographics of the people who have been getting the vaccine. That's what we need. That's the way it's supposed to work. That's really, really, really not how it's going in 50 states in the country. But Dr. Abraham and his colleagues, they have figured out how to do it. And that remarkable success story out of one small pocket of underserved LA should be national news, because everybody around the country should be copying this. What's so stunning about this story is not that it's happening at this one tiny clinic, it's the fact that it's not happening everywhere else, that this isn't the playbook being run at every single place in the country that's administering the vaccine. It's worth understanding what's the secret sauce here, what Dr. Abraham is doing at Kedren Health in South LA, and why can't we do that everywhere that needs it? Dr. Abraham joins us live here next. Stay with us.
We're an institution that started in the 1960s during the Watts riots, when there was no place for black and brown individuals with mental illness to go. And that's how we ended up being the only black psych hospital in Los Angeles. So that's kind of our story. That's who we are at our core, is answering the call. And there was a need here, and that was to figure out how black and brown Los Angeles, black and brown essential healthcare workers, seniors over 65 needed a vaccine, and they didn't know where to go or how to navigate some of these challenges. And that's where we came in and said, we'll figure it out. If we can get to 70% plus of our community with the vaccine in their arms, we will get the herd immunity we need to end this epidemic.
We'll figure it out, he says. That is the very impressive Dr. Jerry Abraham. He's a family physician, an epidemiologist, and a man with a mission to do whatever it takes to figure out how to deliver as many shots of COVID vaccine into as many arms of the vulnerable people of his community in South Los Angeles as he can, as soon as possible. We are a country that is not getting the vaccine to everyone equally. And this is not some ancient problem. Yes, the things that make this a current problem have ancient roots, but we're screwing this up right now. We've only been rolling out the vaccine for weeks, and we're already doing it wrong. We're doing it in such a way that black and brown people, communities of color, are underrepresented among the people who are getting vaccinated. But here's Dr. Abraham and his colleagues in his community who seem to have figured it out. Everybody get ready.
For you all today. Hopefully you got a little taste of what we do here, vaccinating our community. Now over 250,000 doses into the arms of South Angelenos. Much of what you've heard this morning is what we do every day as well. We are overcoming every barrier that stands in between people and their vaccines. No appointment, that's okay. No email, no internet, no cell phone, no address, no transportation. I can't see, can't walk, can't talk. I don't have ID in this country. I don't speak English. I don't have an address because I'm homeless. None of those are barriers. None of those are reasons not to get vaccinated. And we made sure that we removed and stripped every one of those barriers that stood in between people and their vaccines. Our story really begins on December 23rd, Christmas Eve, when I picked up the phone and I politely demanded, where are our vaccines? At this point, Pfizer had obtained emergency use authorization in this country, and we had seen Pfizer land at Kaiser Permanente, Dignity, Cedars, UCLA, USC here in Los Angeles. But what we did see was that there were no vaccines in my community. What I did see was that there were nurses and patients with COVID. We were literally getting COVID and dying from it, and we had still no vaccines. So we picked up the phone and we demanded, where are our vaccines? You know, to achieve health equity, again, as you've heard this morning, We do what we do best. We jump up and down, we wave our hands, we write SOS in the sand, and we demand and take what is ours. And in this case, it were those vaccines. And by New Year's Eve, we had vaccinated 50 of our nurses. But from very early on, we made it very clear that we were going to not only vaccinate ourselves, but we were going to turn to our neighbors, look to our left and right, make sure that our brothers and sisters, Black and brown healthcare workers who had nowhere else to get vaccinated, would have access to a vaccine. We were going to put on our oxygen mask on first and then make sure everyone else had these life-saving essential medicines as well. And that's exactly what we did. From 50 to 150 to 300 to now over 250,000 doses in arms. Once we had vaccinated healthcare workers, we made it clear, don't give us just enough for healthcare workers, give us enough for our community. And when the governor of the state of California declared that everyone over 65 was eligible, we made sure that they had access to these life-saving essential medicines as well. We were going to remove every barrier. As you know, when you deal with different groups of people and their different needs and challenges, we do everything we can to meet them where they are. That's the Kedren way, where we treat people like people and the experience counts. We weren't going to have people waiting outside. We weren't going to have really uncomfortable long lines. We were going to have music and joy. We were going to help grandma and grandpa fill out their appointment forms and get them registered into care and get them vaccinated and get them on their way. And I still remember some of the most important moments was when we looked around us and we told grandma and grandpa, you know, every time that we're able to move you guys along, we're able to vaccinate someone else. Again, that's how we got it done. So that was chapter one, really picking up the phone, where are our vaccines? And that got us to chapter two. Chapter two, the world found out about Kedren. At this point, people knew that Kedren became the exemplary role model, the Center for Excellence for Equitable Vaccine Distribution, really a role model, a template for this whole country. What we did exceptionally well at Kedren was a very high volume of vaccines, equitably administered and distributed, and timely and accurately reported back to the various jurisdictions. That's what the world found out. That's what the LA Times found out. And as a result, the governor came and visited Kedren and saw with his own eyes really what it looks like to achieve health equity, how you race against time, ensuring not a drop to waste, not a minute to lose. Then we went on and I was invited to testify before the United States Senate and really help give these lessons that the rest of the country needed to hear about the urban vaccine rollout strategy and how that's very analogous to the challenges facing rural Alaska, rural Texas, and other parts of this country, and making sure that we all work together to remove every barrier that stood in the way. Chapter two ends with the mayor, Eric Garcetti, coming here, and that's when we announced our latest initiative, Live, Work, Worship, Play, and now where we go to school. As you see right behind me, we're setting up for a busy day of vaccinations here at LAUSD. And at this school, we are going to vaccinate students and teachers and parents and community members. And that's very important for us to do, is meet people where they are, where they live in the housing developments, where they work in the factories, where they worship at churches, mosques, temples, where they play in parks and recs and libraries, and where they go to school. This whole week is dedicated to Education and School Week. We're excited to partner with LAUSD and to get their students vaccinated. And as you heard yesterday in the news, we're looking at full 5 days a week instruction in person. And we're excited to be a part of that story. We're getting our state open for business. On June 15th, we're going to proudly, with the governor, declare the state of California open for business. And that's because all of us have done our part. All of us have gotten vaccinated, and we've socially distanced, and we've worn a mask, and we've washed our hands. And because of all of our contributions to this effort of ending this pandemic, we will be able to open the state. And on July 4th, we hope with President Biden and with Vice President Harris to be able to declare that 70% of adults in our community have been vaccinated. Chapter 3, live, work, worship, play. This is the most costly mile. This is what it takes, the investment, the high price to achieve health equity. Again, this is a race against time, not a moment to lose, not a drop to waste. All these efforts, it becomes harder and harder. The lines aren't wrapped around these mega sites anymore, these mass vaccination sites. Instead, we really must go out there, and part of the Kedren way is that we engage people. We meet them where they are, we educate them, we take the time to answer their questions, whether you're Black, brown, white, or yellow, your body, your rights, your health, your choice, your vaccine. And that's really what it takes to achieve equitable vaccine distribution. And we're going to get there, and we're going to continue to expand this program, integrate it, and we're going to move forward and transition this into a model that revolutionizes healthcare delivery in this country and really brings about a public health infrastructure that was much needed in our community here in South LA. So thank you so much for letting us tell our Kedren vaccine story. We're really excited to be a part of this meeting. We hope that we inspire you. Everyone can make a difference. All you got to do sometimes, pick up the phone, demand what is ours, and go out there. Let's be realistic. Let's make as much change as we can. You can. We did it. You can too. I believe in you. Thank you.
Thank you so much, Dr. Abraham. We can sense from your spirit and the way you communicate why you are so effective. So thank you so much for wrapping up our panel, and now we'll move to the Q&A. I want to thank all of you for your participation, and also welcome back the panelists and our keynote speaker, Dr. Ray Block, to come back to the stage for our final portion of the show, the Q&A with participants. We've noticed that many of you have added your questions to the Q&A and voted by putting your points to our point system. So without further ado, because we have about 5 minutes for the Q&A, I want to jump right in. What I see, we'll go back to the Lillian Moran asks, in terms of language or phrasing, I wonder about focusing on the trustworthiness of the medical system rather than whether Black communities trust the system. For example, the medical system has not yet proven itself unworthy, which has led Black communities to have lower vaccine rates, rather than communities of color have distrust of the medical system, leading to lower vaccine rates. The argument is that the focus of the statement faces the burden of change. What are your thoughts about this? And I thought it might be quite appropriate to have the response for this go to Dr. Block.
So the long and the short answer is I agree wholeheartedly, not only for everything that you just mentioned, but also because this is what we're finding. So one of the research projects that I'm fortunate to be on is actually looking at racial differences in vaccine hesitancy. And to use jargon, what we found is that one of the explanations for it is eroded trust. In other words, like people in my field are very careful with how they talk about differences in racial groups, because what we don't want to say is that there's something magical about the groups that makes them hesitant to receive a vaccine. And I know that sometimes there's a nuance that gets lost in these conversations. It's not really race differences. It's racism contributing to group differences. And the racism that contributes to group differences is what we see in our own research. Whereas if you take into account the distrust that comes historically with places that administer care and companies that take part in the administration of care, you see the gap between African Americans and white Americans, which is what we study, disappear.
Great, thank you so much for that response. I also wanted to say that I noticed that, okay, Dr. Jam, you also addressed this issue of language in your presentation. Would you care to respond?
Absolutely. And as Dr. Block said, I wholeheartedly agree. I think that we first have to make sure that we address the fact that there's been a longstanding history of medical mistreatment amongst minoritized communities. So it's important for us to address that and to magnify that and to build these trustworthy relationships, to be intentional about the trustworthy relationships that we do have, and to make sure that we are intentional about making them long lasting, but being empathetic when we address the fact that, you know, this mistreatment did occur. I can understand why you would be distrustful or have mistrust, but let me explain to you why these vaccines are not that.
Okay, thank you. And Dr. Brunson, there's a question from Quinn Duclos, and many have voted for it. What do you think about the word access? An individual or group can have access, but they would have barriers to that access, as you have stated. As educators or researchers, how would you suggest we change our language?
Oh, well, and I think part of what I'm advocating for is a lot of times this is being captured as, you know, that we're not thinking about access at all, that we're thinking about intent. And that going to Dr. Block and other comments that have been made, you know, that we're encapsulating, you know, even looking at racial and ethnic groups as being homogenous when they're definitely not. So I think that we have to be really particular and to start thinking about this and to start talking about, you know, that there are barriers and there is structural racism, that there are barriers that exist within the system and that are more problematic for particular individuals and groups. And so I think that we need to start really thinking about, instead of going for a general term, that we really do need to start being very specific and explaining what it is that we need.
Thank you. And if I could, yes, Dr. Abraham, I'm glad that you took your mic off. I was going to say that there is a final question about concern about the history of abuse of minority groups for medical research in the past and ways to overcome that is the question. I think that what you're doing is an example of that, but would you care to elaborate?
Absolutely. So excited to answer this question and definitely want to build off of what Dr. Block and Dr. Jam and others, Emily, Dr. Brunson here has also added. It's really important that when we looked at the issues around access versus hesitancy, you saw early on data around Latinx community and the Black community saying there were high rates of hesitancy. And yet what we saw in our community were, where are our vaccines? Don't confuse the lack of access for vaccine hesitancy. And then when we really did get into those reluctance issues, whether they were barriers to transportation, paid time off, childcare, etc., those were the real barriers, again, getting confused for distrust, mistrust, and hesitancy. But what we do know is that the Tuskegee trials were real, that the abuse of Henrietta Lack cells were real, that undertreatment of pain is real in our community. So to really come at the table and say, we acknowledge and we are here. We want to be trusted healthcare professionals and partners in your body, your health, your choice, your rights. So we come from that place and we want to spend time with you. We want to engage you, want to make you feel comfortable. We're not here to do anything to you. We want to give you the information so that you can choose and you can do what you need to do with that information. We hope you make the right choice. And in this case, we really do hope that everyone here gets vaccinated so we can get back to all the things that we love to do, including hugging and kissing on grandma. Thank you so much.
And thank you, Dr. Abraham. Yes, Dr. Jam, closing thoughts?
I could not echo what Dr. Abraham said. I feel like he's my spirit animal, but I could not echo what he said enough. At this point, we've actually decided to start going into people's homes, and we have a strike team, and the president of our university actually joins those strike teams. And we make access even more of a verb. We go into these homes and we vaccinate them there, because then even coming as far as to where we popped up our clinic is a barrier, is sometimes, you know, an issue. So we go there and we talk about the vaccine, and we've been able to vaccinate people right there on their front porches. So, I mean, a friend of mine, she gave me this analogy. She said, when you hurt a friend, you do everything that you can to make sure that you repair that relationship. So that's how we have to look at these relationships that we have with these minoritized communities. We have hurt our friends. So now we have to go and we have to do everything that we can to make sure that we repair these relationships, that we bring these vaccines to them, that we create equitable distribution, that we meet everybody at their specific place. And to do that, we have to go just above and beyond.
Well, thank you so much. I really appreciate that, Dr. Jam. Dr. Abraham, I see that your mic is off, and forgive me, Diana, but I'm going to go ahead and let him get the last word there, and then we'll wrap.
Yeah, no, I just wanted to say that it's so essential that people know that this is their vaccine. This is for them. There were Black and brown people in the clinical trials. We really need to understand that why people may be on the fence and not let them ever feel that the burden is on them, as we said here. And so really, I think, what Ray has said, what Jam has said is so critical to understanding why we are where we are and how we don't make those mistakes again. It will be criminal if people die, if Black and brown people die the next go round, this type of pandemic strikes our community. And these things are looming in our future. We won't let it happen again. And that's because we've learned way too much. And what we need to know, that's why it's very important here at Kedren, we let people choose their vaccine, Pfizer, Moderna, J&J. So we're not imposing any one vaccine on anyone, but it's really important that people know that we want to survive. We want to survive just as much as other skinned people. We want to survive just as much as other zip codes and other socioeconomic strata. And if that's what this vaccine does, then by golly, we're going to keep vaccinating till our entire community has access to these vaccines. Thank you.
Well, thank you. We see, we understand, and I think getting the word out is so critical, which all of you, our presenters, Dr. Abraham, Dr. Brunson, Dr. Jam, Dr. Abdul-Mutakabbir, and Dr. Block. Thank you so much for the wisdom, the insight, and the critical knowledge that you've imparted to all of us. Forgive us, those of you who've posted your questions in the chat. We will endeavor to share those questions directly with our panelists and keynote speaker. And so I want to, as we wrap up, say, don't forget to complete the individual session evaluations and the overall conference evaluation by visiting the conference homepage. So thank you again, and I do hope that you'll enjoy the remainder of the conference. Goodbye, everyone.
Bye-bye.